Hello and welcome to this fourth year dermatology lecture. My name is Eliza and I'm one of the foundation doctors at Sandwell Hospital. Today we will focus on eczema. By the end of this session, you should be able to define eczema and list some common examples, understand the etiology of atopic eczema, describe the typical clinical features of atopic eczema, explain the management of atopic eczema, and list some common complications. So what is eczema? Eczema is also called dermatitis and comes from a Greek word meaning to boil. It is an inflammatory skin condition in which the skin becomes dry, itchy, and red. There are several different types of eczema which are important to be aware of. The most common form, and the one that you will probably be most familiar with, is atopic eczema, which we will focus on in this lecture. Other forms include seborrheic dermatitis, which mostly affects the scalp and face, venous eczema, which affects the lower limbs due to venous insufficiency, and contact dermatitis, which affects areas of skin exposed to irritants and allergens like soap or nickel. This lecture will focus on atopic eczema. Atopic eczema is a chronic condition characterised by flares or exacerbations which can occur as often as 2 to 3 times a month. It affects all ages but is most common in children, affecting 1 in 5 children. Most cases occur before 5 years of age, and it tends to improve in adult life. Atopic eczema is part of the atopic triad. The atopic triad is a set of conditions, eczema, asthma and hay fever, that tend to occur together and are linked to increased activity of the allergy component of the immune system. So what causes atopic eczema? There is no single known cause for atopic eczema, but it is thought to be linked to a defect in the skin's barrier function. The main function of the skin is to restrict water loss and prevent the entry of irritants, allergens, and skin pathogens. When the skin barrier function isn't working properly, this causes water loss, leading to dryness and itching, and makes the skin susceptible to allergens and infection. As with most conditions, eczema results from interaction between both genes and the environment. Up to 70% of people with atopic eczema have a positive family history for atopic disease. Recent evidence suggests that a mutation in the filaggrin gene, which is a structural protein in the epidermis, is a likely cause for almost 50% of cases of atopic eczema. In addition to the genetic component, eczema can be triggered by environmental factors such as soap, wool, and animal dander. In terms of diagnosis, eczema is a clinical diagnosis. It is a poorly demarcated, itchy, erythematous, dry, scaly rash. Eczema can either be clear, where the skin looks completely normal, or it can be mild, moderate to severe, based on how red, itchy, and dry the skin is. In severe eczema, you may see bleeding, oozing, or cracking. In chronic eczema, you may see lichenification, as in the picture on the right. This is when the skin becomes thick and leathery due to continuous rubbing or scratching. The distribution of eczema varies with age. In infants, it often affects the extensor surfaces, face and scalp, whereas in older children and adults, it mostly affects the flexor surfaces, such as the elbow creases. It is also vital that you assess the psychological impact of atopic eczema. Ask the patient about the effect on their daily activities, sleep and mood. There are specialist questionnaires available to give an objective measure of quality of life. So now on to the management of atopic eczema. As with most conditions, management can be split into conservative and medical management. In terms of conservative management, educate the patient on the condition. Explain that eczema is a chronic condition characterised by flares which can usually be controlled with appropriate treatment. Provide information on recognising the signs of symptoms of a flare and advise them to avoid any trigger factors known to exacerbate their eczema. Advise that they should avoid scratching the eczema and keep their nails short. You can use anti-scratch mittens in babies. Provide information on support groups and information leaflets from websites such as the British Association of Dermatologists. Medical management of eczema can be subdivided into 3 categories: emollients, topical treatments, and systemic treatments. We will look at each of these in turn. Emollients are moisturisers and are essential in the management of eczema because they enhance the barrier function of the skin. They come in different forms: gels, lotions, creams and ointments, which all have different compositions. Prescribe emollients according to the dryness of the skin and individual preference. Generally, ointments are greasier and better for very dry skin, but they are usually poorly tolerated when compared with creams. Key points to consider: emollients must always be used even when the skin is clear. They should be applied liberally and frequently, at least 4 times a day, and should be massaged along the direction of hair growth. Generally, appropriate quantities to prescribe are 250 grams a week for children and 500 grams a week for adults. So now on to topical treatments. Topical steroids are usually used for flare-ups to treat inflammation and come in different potencies depending on the severity of the flare. Generally, use less potent steroids on the more delicate skin of the face, genitals and axillae. A normal treatment duration would be 5 days on delicate areas and 7 to 14 days on other areas, and continue for 48 hours after the flare has been controlled. Application is based on fingertip units. 1 fingertip unit is equivalent to about 500 milligrams and is sufficient to treat a skin area about twice that of a flat hand. Topical steroids can also be used indefinitely for maintenance treatment for areas prone to frequent flares. Side effects of steroids are usually local, such as thinning of the skin, permanent striae or acne. They can have systemic side effects as well, like Cushing's syndrome, but this is rare. If eczema is not controlled by maximal steroid therapy, topical calcineurin inhibitors, tacrolimus and pimecrolimus, can be used. They are immunomodulators and work by inhibiting T-cell activation and preventing the release of cytokines, dampening down the local immune response. Unlike topical steroids, they don't thin the skin. There are a few systemic treatments available. Antihistamines can be used for severe itch. Antibiotics or antivirals should be used if there are signs of infection, which we will look into further in the next slide. There are a number of immunosuppressants used to treat eczema. Oral prednisolone can be used for severe flares to gain rapid control in the short term. If ongoing oral medication is required, non-steroidal immunosuppressants may be used. You may be familiar with them from other conditions. For example, methotrexate is often used in rheumatoid arthritis and is also a chemotherapy agent. In addition, a relatively new treatment is dupilumab, which is a monoclonal antibody given as a subcutaneous injection, and it blocks interleukin 3 and 4 to reduce inflammation. Finally, phototherapy is another option. It is not a systemic treatment, so it's in brackets, but it involves ultraviolet A or B treatment several times a week for several months. Complications can be divided into 2 categories. The first is psychosocial issues, such as sleep problems, issues concentrating at school, and low self-esteem. This is why it's always important to assess the impact on a patient's quality of life when taking a history. The second complication is infection, which can be bacterial, viral, or fungal. Bacterial infection is usually caused by Staph aureus and may present as impetigo or worsening eczema, where you may see increased redness, oozing, and crusting. Viral infection is usually caused by herpes simplex virus and causes eczema hepaticum. This looks like clusters of itchy vesicles and punched out erosions, and the patient is usually systemically unwell with fever, malaise, and lymphadenopathy. It is a medical emergency and can have serious sequelae, such as eye or meningeal involvement. So the key points to take away from this lecture are that eczema is an inflammatory skin condition. There are different types of eczema. There is no single known cause for eczema, but both genes and the environment play a role. Management can be split into conservative and medical, and emollients are key. And finally, eczema, like many dermatological conditions, can have a significant psychosocial impact, which must be assessed. Thank you so much for listening, and I hope you found this lecture useful. If you have any questions, feel free to email me on the address provided.